So good morning. My name is Eleanor Wilson, and I'm the board chair of the Michael Smith Foundation for Health Research. And I'm so pleased to be here today to introduce this panel. As you may know, Michael Smith is a major financial contributor to the BC Support Unit, as well as a key collaborative partner on activities such as knowledge translation and capacity building. And it has been so exciting over the last several years to see the huge growth and development that has occurred in the BC Support Unit. So today I have the pleasure of introducing 5 individuals who will lead a discussion on how patient-oriented research is having a positive impact on the health system in BC's regions. And because of our timing, I apologize ahead of time to the panelists. I'm cutting the bios I was given for all of you a little shorter. So first I want to introduce the moderator for the panel, Chad Dickey, patient partner. Chad is Dene from the Fort Nelson First Nation in Northeast BC and is the board chair of AVI Health and Community Services, formerly AIDS Vancouver Island, and he contributes his patient voice to various health and community groups. We also have with us Mark Blandford, Executive Director, Primary Care and Seniors Health with Island Health. In this role, he helps lead the transformation of primary care and community-based health services for seniors and those with complex medical conditions. Linda Dempster is the Vice President Patient Experience with Fraser Health, and she provides strategic leadership for the patient experience portfolio, ensuring that the healthcare journey is both high quality and seamless for patients, clients, residents, and their families. From Northern Health, we have Dr. Denise Jaworski. She is a general internal medicine physician in Terrace, where she is also the co-site director for the Integrated Community Clerkship Program for third-year medical students. In this role, she works closely with primary care providers and Northern Health to support people living with chronic disease. And last but not least, Dr. Anne-Marie Visokis is Vice President, Planning and Research at Interior Health. In her role, she provides operational leadership and oversight for Health Authority-wide planning. Her portfolio is also responsible for research, information, analytics, and evaluation support, as well as primary and community care transformation planning. So you have a broad spectrum of experience here, and I'm going to turn it over to Chad to moderate the panel. Thank you.
Thank you, Eleanor. That was wonderful. We're just going to jump right into it because we do have to end this by 10:45. So the objective of this panel is to, excuse me, this is my very first time moderating. The objective of this Health Leaders Dialogue is to provide an opportunity to hear from high-level health system leaders from different geographical locations in BC with respect to how patient engagement is positively impacting their health populations. Each panelist will have up to 5 minutes to share their perspectives and how incorporating patient-oriented research is aligning provided services and supports to improve patient-centered care and patient engagement. Our first speaker is Linda Dempster from the Fraser Health.
Thanks, Chad. So I just want to let everybody know that I became a grandmother 1 month ago, and best feeling ever. And this was just given to me by Mandy. It was made by one of our patient partners on our Regional Patient Advisory Council for my little guy. So it was very sweet of her to do that. So there is a clicker here, right? Do you know where it is?
Clicker right there.
Oh, that's it. Okay, great. Never seen one like that before. So I thought what I'd do today is just give a quick overview of Fraser Health, and then I'll go into some examples of the work that we're doing that involves patients and our patient partners. So this is Fraser Health. It's quite a large geographic area. We actually serve 1.8 million residents of BC. We're the fastest growing health region in Canada, and our population is expected to increase by 8% to almost 2 million by 2023. We actually serve 1 in 20 Canadians. We have over 60, almost 63,000 Indigenous residents. That includes First Nations, Métis, and Inuit, and that represents about 3.7% of Fraser Health population. Our focus is actually on using the quadruple aim. So we are looking for value for money, for the provider experience, for good population outcomes for our patients, as well as the patient experience. So I just thought I'd give a couple of examples of things that we're doing. In the top right-hand corner, you can see this is one of our patient partners, Sharon Chamberlain, who has worked really hard. Our entire Regional Patient Advisory Council did a co-creation of our shared commitments. So we partnered with staff, we partnered with patients, we partnered with physicians across the entire region to develop our shared commitments document. And you will see that shared commitments on every unit across Fraser Health. Sharon was also instrumental in being a patient partner on our PQI, which is our physician quality improvement work as well. In terms of research, the SPORE has over 89 patients involved with them, with the center. 29 are patient partners on research teams, and the rest are actually on various governance committees. This is another example of how we're actually using patient information in the moment. This is what we call our real-time patient experience survey. We have it rolled out on a number of units, and managers are actually using the real-time data to actually make changes in the moment on their units. So one of the things that we have been really focused on for the last number of years is hand hygiene rates for staff. But we actually failed to recognize that we actually weren't offering anything for patients to wash their hands before meals as well. So that was a really important learning for us, and we've made some really nice improvements based on that information. I took this slide out of our the provincial patient experience measurement group that was done using surveys in our emergency departments. And this one in particular stood out for me because it really focused on compassion. And Lawrence and I know a lot about what we're talking about here. There's a lot of research on compassion, and I think that that's something that over the next number of years I'm going to be really personally focused on, is increasing the amount of compassion that we have, not only for patients, but for staff as well as for each other, because I think it's a very important thing for us to focus on. We also have engaged patients. This is the Royal Columbian Hospital redevelopment. So we have engaged numerous patients on multiple different committees in the redevelopment and the actual design of the build. And I know that we're very excited to be actually hardwiring engagement into all of our redevelopment opportunities. I'm looking at behind Lawrence there. One of our patient partners that helped us to design and worked on what we call our technology-enabled patient engagement. And so we actually engaged with patients to determine what kind of areas that we could use to actually focus on, and what kind of technology that we could do to leverage things and actually increase the experience for patients. So things like we're developing a portal called MyChart. We've been partnering with Sunnybrook Hospital back east to develop a patient portal so that people can actually have access to their information. It's very important that people have access to their information. Patient education materials, for example, and then virtual health as well. I just thought I'd give a couple of examples of some of the areas that we focused on in terms of virtual health. Telepsychiatry, for example. ICU rounds, we now have, I'm coming. ICU rounds, we have intensivists from Royal Columbian and Surrey Memorial actually delivering rounds in some of our smaller hospitals. And they've made some significant differences in length of stay and getting people out of the ICU, which we all know is really important. Virtual reality, I won't get into the details here because I'm running out of time, but this is just an example of how we're engaging patients and little children in using virtual reality to actually calm them down before they actually have a procedure. So those are just a few examples, so thank you very much.
Thank you, Linda. The next person we have up is Mark Blandford. He's the Island Health Authority's Executive Director for Primary Care and Seniors Health since January 2019.
Thanks, Chuck. Good morning. I'm somewhat the fraudulent member of the panel, I think. I'm kind of the imposter administrator in the sense that in terms of research, it's often the last thing I'm thinking about. I think I've been asked to come here today to talk about the operational leader's perspective and try and bring that to the table to support you in developing your research plans with your patient partners. Doesn't mean I'm not interested in research. In fact, my kind of first foray into research as an operational leader was as the clinical director of Victoria General Hospital 3 or 4 years ago now. And Cindy Triton, who's our Director of Research at Island Health, came to me and said, we've got this great project on C. difficile we'd love to have you involved in. I'm an occupational therapist, I'm leading an acute care hospital. What do I care about C. difficile? But Cindy's a very compelling person. She's since become a speed dial on my phone. And whenever I'm looking to get somewhere quickly, Cindy often pops into the way of my journey. In a good way, Cindy. So C. difficile came to life for me. It was a project by Dr. Christine Lee and a bunch of partners, some of you probably in the room here today. And it was a unique project to spread the use of fecal transplant matter. And the thing that was really driving my thinking at the time was acute care hospital overcapacity, which is one of the big issues that's facing us as a healthcare system. This morning I had something like 15 emails before I even got to the airport regarding overcapacity in our acute care hospitals on Vancouver Island. I guarantee you every operational leader you interact with will be bothered about overcapacity. So when you're talking to them about C. difficile in an isolated research project, it's almost the last thing they're interested in. But when I met the patient partner, Wayne, and heard his wife's story, whose name escapes him, I'm afraid, I heard Wayne's story of heartbreak, how a fully functioning teacher suddenly had her life turned upside down because the C. difficile she was suffering couldn't be treated, and how this life-changing treatment, the fecal transplant, could change her life. It changed my way of thinking. I was compelled by the story, but I was further compelled by where I saw the evidence taking us, which was reduced hospital overcapacity. We had something like 50 patients at any given time in the hospital in one stage or another being treated for that particular disease. Can they be treated somewhere else? Do they need to be in the hospital? I'm in. So my point number one is, as a decision maker, I'm looking for research that speaks to the compelling things that keep me awake at night. And it sounds crass, but I don't have a lot of time to talk about things which are ethereal and way off in the future. But something that speaks to my immediate concerns is something that I'm paying attention to. And the partnership we have at Island Health with our research office and our patient partners, by the way, we've got over 100 patient partners involved in active research at this moment in time. Just got that 2 minutes ago by text from Cindy. But that's a compelling thing. Overcapacity is today's real problem. A growing population, growing frailty in the community. We're struggling to manage that situation, particularly in Vancouver Island. We have way fewer long-term care beds. I'm responsible for long-term care. than the other health authorities. And for instance, we have about half the critical care ICU capacity of the other health authorities. So that all impacts our thinking on a daily basis. So when you come to us with a request to support research, we're applying that lens to it. And it's really important to us, particularly if there are financial implications for that research to directly impact the things that we're worried about. Primary care transformation is pretty much, I bet most people in this room are aware of it. Many of us are involved in it. It's a tricky, difficult file, but will lead to great changes and transformation in healthcare for people in the future. So figuring out what works, why it works, what we need to improve upon, that's crucial for us. And there's not a lot of evidence in some of the key areas where we're making big financial decisions. Something that doesn't get an awful lot of play are the social determinants of health. Former job, I was the Deputy Seniors Advocate for the province, worked with Isabel McKenzie. One of the things that she impressed upon me in that role, something I never really paid attention to, were the social determinants of health. Seniors in particular are making decisions on whether to buy medications or pay for housing or pay for a grab bar or a ramp or many other bus passes. The social determinants of health are critical to the future of our healthcare system. We have to find a way to support people, particularly in the big cities where the average rent is $1,100, $1,200 in Vancouver, $1,000 in Victoria, and the median income is around $24,000 a year. So if more than half your income is going to rent, you're making big decisions about your healthcare. So when we're looking at research, I'm certainly interested in really effective interventions related to the social determinants of health. And so in conclusion, I would just say, and obviously we're going to have a bit more time to ask questions. I think for me, as a decision maker, I would say to you as a researcher, get to know who your decision makers are. Cindy and I have coffee quite often, and I get to, bleat on to Cindy about the problems that are keeping me awake at night. That helps frame some of the research we're doing. And again, as I said earlier, to get my full attention as a decision maker, and I'm just one, I have to be fully engaged in the why. Why is this important? How does it relate to my operational imperatives, which are crushingly on top of us all the time? And finally, just think about what the government priorities are. I'm kind of randomly going around the bush here, but government priorities change, but when they change, we need to pay really close attention to them because they are our paymasters and they direct us. So I would just say, that's kind of what I bring to the table here today, and I'd love to have more conversations with you as to kind of what decision maker is thinking. But I would give you the caveat that I'm not a researcher. Thank you.
Thank you, Mark. Though you're not a researcher, it's very important that you're here I think it's really, your voice will be valuable in this conversation. Next up, we have Denise Jaworski, is a general internal medicine physician in Terrace, BC, where she is also the co-site director for the integrated community clerkship for third-year medical students. Welcome, Denise. And your little one.
Great. Thank you so much. As a settler, I am honored to be here on the unceded Coast Salish territory. Just a little disclaimer, I'm a physician working within the Northern Health Authority, but I don't hold a leadership position there and I don't have any direct decision-making capacity. I know Northern Health is deeply committed to engaging patient partners in policy and research, but the views I expressed today are my own and don't necessarily represent those of the Health Authority. Today, I will speak briefly on strategies to influence decision makers and existing challenges to patient-oriented research. And she's finally asleep, so if you guys, even if you boo me off the stage, this is still a success from my point of view. So as a physician, but not a decision maker, I need to employ strategies so that my research has influence over those who can make decisions. The first, there we go. The first strategy that I use is to align patient-oriented research priorities with those of decision makers, and this echoes a lot what Mark just said. There are tons of priorities that are shared among both patient partners and decision makers and health authorities, so focusing on those may give you the momentum to take your project off. I also find that engaging decision makers early helps when you want to take your research forward and you get to a stage where you want to take your research findings from knowledge to action. So if you've had a decision maker at the table from early on, your research is going to ask the right questions. It's going to consider the right factors to ensure that the findings are relevant to decision makers. The third strategy that I think is important is to involve many patient partners. If you invite one patient partner to sit on a committee, they can at times feel intimidated and struggle to find their voice. However, if you invite many patient partners, it shifts the power dynamic and can amplify their voice, giving them more influence with decision makers. In some of the projects that I've been involved with, I've aimed for a 1+1 number of patient partners, meaning that patient partners form the majority on advisory committees. Thanks. In the past several years, there have been huge efforts to develop and support patient-oriented research. However, as with all changes, there can be barriers and challenges along the way. Existing structures and policies may not always be appropriate for patient-oriented research. So this is my outside of the comfort zone slide. Research funding agencies will only release funds to approved institutions, most of which are academic. Only those with academic appointments at eligible institutions can become a principal investigator. This structure prevents patient partners from having control and ownership over research. If we want to do research that centers around the patient experience and priorities, we need mechanisms to allow patients to take the lead. Finally, I would like to share a story that illustrates how rules around funding administration can impede patient-oriented research. For most universities, the standard procedure for travel expenses is to submit a travel expense reimbursement claim after the travel has been completed. Additional expenses, such as meals or taxis, are then reimbursed a few weeks after the trip. I was the principal investigator on a knowledge translation project involving a meeting of patient partners from across Canada for a 3-day meeting. The majority of patient partners were from low-income households. In planning for the meeting, our patient partner co-lead told me that it is important to provide patient partners with honoraria as well as cash upfront to cover per diem expenses. The finance department at my institution worked hard to ensure the honorarium checks would be available in time for the meeting. I also requested a cash advance for the per diems. I was told that this was not possible and that since they would get their honorarium checks when they arrived, the per diems could be reimbursed at a later date. This is how it was always done. I wasn't happy with this, but it seemed like a reasonable argument. So I arrived at the research meeting, pleased to have the honorarium checks in my pocket and thinking that the patient partners would be happy. However, before the meeting started, there were requests from many patient partners to help them get to the bank to cash their checks. We had to push back the meeting by several hours so we could help the patient partners cash the checks. What happened next was my complete failure to recognize my own privilege. When I go to the bank to cash a check, I deposit it in the ATM and can immediately withdraw it. There's no hold. I've never had a problem cashing a check. This was not the case for many of our patient partners. I had to bring some of them to 3 banks before we found one that would allow them to cash their checks. One night, dinner was not provided at the meeting to allow for some downtime for everyone. Patient partners were to be reimbursed for per diem expenses through submission of a travel reimbursement claim. I later found out that one patient partner was unable to cash her check and had to borrow money so she could have dinner that night. We lost 2 hours of our meeting as we ran around cashing checks, but that was not a big deal. What was a big deal was that we were trying to create a safer space for research, where academic team members and patient partners were seen as equals on the team. Instead, we started out our meeting reminding them of their daily struggles with poverty. As a final take-home point, I will leave you with this. If you are fighting to adapt research based on patient partner recommendations, and you are told that something is not possible, then you need to fight harder. This is the only way to truly achieve patient-oriented research.
Thank you, Denise. That was wonderful. I really liked the framework that you laid out for engagement, plus also sharing those stories really resonates with me. Our next presenter is Anne-Marie Vissokas, the Interior Health Authority Vice President for Planning and Research.
Thank you so much. It's a real privilege to be here today, and I especially want to thank Denise for your comments. It's such an important reminder that so often we come from our health authority or organization perspective, and it's so important to remember the needs of our patient partners and the work that we do. I'd like to just share with you a little bit of background about the Interior Health Authority in case you're not familiar where we're situated. We cover the southeastern part of the province of British Columbia, approximately 750,000 residents, so considerably smaller than Fraser Health that Linda talked with us about today, but a very large geographic area, 215,000 square kilometers. And that really is one of the key points I'd like to highlight about Interior Health and the research that we do, and that is that we cover a very large rural and remote area, many, many small communities. Often patients and residents living in those communities are required to travel for services, so we always consider very much in our research strategy, as well as our planning and service delivery, that rural and remote context. The other thing I'd like to highlight is that we have our area that we cover is the same as the traditional unceded territories of 7 First Nations, and we have established letters of understanding with those First Nations and worked very hard over the last number of years to improve the working relationships with the First Nations with whom we share a geographic area. 8.8% of our population are First Nations. We also have a number of Métis residents and a number of other immigrant and diverse cultures that reside in our area. I should just mention as well our research team. Leslie is here today along with Kim and Wendy. We have a really active research department at Interior Health. I'm very, very grateful for the work that they do, and if any of you are interested in partnering on research, they are absolutely the people to connect with who can help you get linked in with decision makers and others to enable that research activity. So huge thanks to our research department. And as a result of the work that the research department has done over the last few years, we have a very large number and a diverse array of research initiatives focused around patient-oriented research underway at Interior Health. Far more than I could share with you in the 5 minutes that I have this morning. And I would like to just highlight the first research initiative that's covered up here. This is not work that I personally have been involved with, but it's been done in partnership between the Ktunaxa Nation, and you may have noticed on Dr. Adams' slides earlier, the traditional territory of the Ktunaxa Nation covers the southeastern corner of the province of British Columbia. So it is very much a partnership between the Ktunaxa Nation, Interior Health, and the University of Victoria, and I would like to acknowledge the Ktunaxa Nation Community Advisory Committee that largely guided this work, along with Hereditary Chief Sophie Pierre, Dr. Christopher Horsethief, Leslie Bryant, who's here today, Dr. Sana Shahram, as well as Dr. Bernie Pauly, who I believe is also here today. And through this research initiative, it was very much guided by a community advisory group that looked into the question of what would a healthy community look like. And as a result of that work, the focus was on creating a Ktunaxa community model of wellness that could be responsible for addressing that question of what a healthy community would look like. And I think that there was a very rich set of findings that came through that work, including a recognition of connections ancestry, history, looking to the future, health equity, many other factors that are really, really important for us to remember. And for us in interior health, then the second phase of that work is to explore how we can learn from the Ktunaxa understanding of health and wellness and use that to inform the way we plan and deliver services. A couple of specific examples of how that's coming into play is the work that we do on cultural safety and humility training for our staff, as well as the development of primary and community care, where the findings from the Ktunaxa community work will absolutely be considered in the primary care network development that is rolling out in that particular area. As I mentioned, we also have letters of understanding with First Nations communities and many other initiatives. I would also like to give a shout out to the very, very active Interior Health Patient Engagement in Research Committee. They have really come together and been very, very helpful and influential in promoting patient-oriented research. The other thing I'd like to just mention, I think there's really been a confluence of several things coming together over the last few years that are very helpful as we consider patient-oriented research as well as planning and service delivery. Not only do we have the SPORE initiative, but we've also got a very active person and family-centered committee in the interior health that we can use to review policies and receive advice from. We've got the Patient Voices Network through the BC Patient Safety and Quality Council, very active engagement on a number of important files for us. You heard Mark mention primary and community care transformation, as well as long-standing resident and family committees at long-term care facilities and other programs and initiatives. And I think the confluence of all of those activities is really helping us in our focus on patient-centered care. I would just like to highlight, in particular, in the interest of time, one point, and it ties in with comments that both Denise and Mark provided to us, and that is around capacity. And I'm looking at Sterling here, an allocation of limited resources, time, as Tom pointed out to us, being perhaps the most scarce of all. We have 6 strategic priorities in interior health. They're highlighted in the visual up there. They are consistent with the provincial strategic direction. They are outlined for us in the mandate letter from the Minister of Health to our board of directors and consistent with our detailed operating expectations from the Ministry of Health. So that is really a primary focus for us in the planning work that we do and the specific things we have to execute on each year. They have stayed fairly consistent for us over the last couple of years, and we're hopeful that they will remain consistent into the future. But you can see, for example, that Aboriginal health and primary and community care transformation are really key priorities for us. We've got detailed work plans, expectations that we're aiming to deliver on. So to the extent that it's possible to align with some of those key strategies, it's much more possible for us to gain decision maker time. That's not to say that we don't do patient-oriented research in other areas. We do. There are many, many projects underway, but in terms of time and capacity, that is a real important consideration for us. So I thank you for your time today and really look forward to the conversations over the rest of the day. Thank you.
Thank you, Anne-Marie. Thank all of you for your presentations. Just a brief recap. Linda from Fraser Health Authority talked about shared commitments, culture change and system change, and the importance of real research and surveys and real-time data, and also compassion, the need for compassion for patients and for staff. Mark spoke about operational leadership and implementation, and also how research and practices can directly affect really value-based care, and also recognizing the importance of the social determinants of health. Denise gave a meaningful presentation, a framework on engagement and on things to consider in doing patient-oriented research, but also the importance of recognizing challenges that some of your patient partners may have. Anne-Marie brought a very good message around the need for what a healthy community looks like, and the importance of cultural safety and cultural and social humility, and the importance of capacity building and allocation of resources. I hope we're going to have a very lively, informative discussion for you, and we'll have questions at the end. We're just, let's see, we're at, I want to end this on time at 10:45, so I'll throw the first question out to everyone, and then we will go from there. First question would be open book. How are decisions being made by the Health Authority that focus on patient-oriented research? And what are the competing interests? If anybody wants to take that one, jump in.
Okay.
Yeah, at the bottom.
Good morning. So we have a fairly formal structure in our health authority. We have a research committee. We've got a very active research, patient-oriented research group. As I said before, we have about 100 projects underway with about 150 partners involved. And I think we're linked very closely to an operational executive director committee, which I sit on. And so I think what we're trying to do is to bring research very much to the operational leadership as quickly as possible and as early as possible. I think that's where the relationship piece comes in. Often we're very well aware of the research coming long before it comes to us formally. So I think that's the key. And then the executive medical director for research sits at our operations committee, so he's very informed as to kind of what our operational priorities are. And they actually, I gave you a brief overview of kind of what we're looking at systemically, but those operational priorities do change based on kind of emerging threats and conditions. So I think we've got a fairly formal structure, but I would say the informal structure is very much alive and well, and that's what kind of, I think, speeds us to get so many research projects underway relatively quickly. And the patient partners are really a core in that process. I don't know if I probably know about half of the 150 that we have. They seem to pop up just about everywhere, which is great. So I don't know if that answers the question, but it gets us going.
And I would just add, we too have a process for reviewing research proposals, considering both research ethics and operational impact. But I would say one of the really important findings in the example of the partnership with the Ktunaxa Nation as well as Interior Health and the University of Victoria is to engage very, very early rather than coming with a final research proposal and maybe the day before the letter of intent is due and saying, who will sign on to this? It is so important to engage early and be clear on whether this is actually relevant for the population of interest who we are asking to engage in that research.
I just wanted to comment on there are things that you can do within the health authorities in terms of facilitating an infrastructure to support patient-oriented research. So one of the things that we're very excited about is the fact that our patient experience group is actually now under the same umbrella and portfolio as the research group. So Kate and Magdalena and Ribleen and Mandy. And so we're really focusing on developing those partnerships and actually looking across the organization rather than sitting in silos. And I really see that there's a huge opportunity for us to develop those partnerships internally to actually increase and move the dial forward very significantly as we move forward. So.
I can't, is that on? I think so. I can't really speak about decision-making directly, but in terms of competing interests, in rural and remote communities, it's very common to have a lot of staff turnover, a lot of man-powered health human resource issues, and so that's one thing that we struggle with in our communities. So anytime that patient-oriented research can be sort of linked with direct and immediate improvements to patient care, that can help to sort of overcome those competing interests.
Thank you very much. Hello, hello, hello. Not turned off. Hello? Yes, here we are. Okay, one question. The move towards primary care networks and patient medical homes mandated by the province of BC, how does that open up opportunities for patient-oriented research in your areas? Any ideas?
Maybe I'll just start by sharing an example of one of our Wave 1 areas, which is the South Okanagan. Before talking specifically about research, I would just like to really appreciate and acknowledge that the development of the PCN proposal was done very much as a partnership between the Penticton Indian Band, the local division of family practice, and the community people representing Interior Health. So there was an active collaborative group that was meeting regularly to prepare both the expression of interest and then the more detailed proposal. Because it's still fairly early days, I don't think we've actually launched a lot of research, although there have been some discussions about how best to go about evaluating that we're actually achieving the desired objectives of that work. Again, engaging with the 3 partners in the development of the PCN to ensure that we're recognizing the patient experience, the staff experience, as well as the outcomes, to tie into Linda's comment about quadruple aim.
I just wanted to add to that too, that I watched my 87-year-old mother track my father's INR on an Excel spreadsheet and try to present it to the healthcare providers, and didn't get really a lot of traction in that. So that's something that I think we need to start thinking about is, my mother had a written healthcare record of every single procedure my father had, and it was not really taken seriously. So that's something that I think we need to actually make some changes in as well.
I'd concur with what's been said. One thing that's coming up recently for us is the effect of the urgent primary care centres that we've developed and how they impact the emergency room utilisation. The notion in one of the expected outcomes was that we would reduce reliance on emergency room utilisation, and that's in fact not proven to be the case. The UPCCs are attracting a lot more clients with a lot more critical conditions than we expected. And so looking at the patient experience, because it's quite different if you go to an urgent primary care clinic, it's a different service to what you'd get in an emergency room, but people are expecting very similar service. So, how can we support clients in making choices? I think it's a difficult one, but looking at the patient experience, particularly those who are sort of CTES 3 and above, who show up at an urgent primary care, how can we support whether we should be growing UPCCs, enhancing them, because that's a big financial decision for us, or indeed looking at how we can divert people to the right place for their care. So that's an area of real recent interest for us. But I think it's early days in the primary care. We're still working really hard with the divisions, with our Indigenous partners and others to get the networks off the ground. So early days, but certainly that particular issue's front and center for us in the last few weeks.
that or opportunities that the primary care homes bring for patient-oriented research is the creation of teams and communities. So you bring all of these people together focused on the health of patients, and it opens up the opportunity for having peer health navigators within these primary care homes as well, and you get these people together and they can start discussing ideas that will help, that will ask sort of locally responsive questions. So patients in my community probably don't care about the health impacts of pineapple farming, but they may care about the health impacts of some of the local industry in the area, or something like that. So I think when you have these local teams together, you can really focus on local priorities, and those often will address patient priorities.
Thank you. That was wonderful, because I think what you, all four of you touched on was around the importance of creation of teams, team-based care, and the move towards a wellness approach, but also the value of how research and patient engagement can move the ball down the field towards better healthcare population health. Lastly, we're just about 7 minutes left, so I'm going to open the floor up to any questions. So please, there'll be people with microphones coming around.
Hi, I'm Delia Cooper, and I'm on the board of BC Academic Health Science Network. I'm really, really pleased to have you all here, and I'm excited about the programs that you're talking about. Thank you very much, Linda, for sharing about the MyChart, which is coming to Fraser Health, and I hope it's spread across the province really soon. My question today, though, was for Vancouver Island, and I'm really excited about the research being done on C. difficile. Can you give us any idea when we will be able to spread that to the rest of the province as a real possible treatment?
I'm going to point somebody out in the audience to you. This lady in front here, Cindy, and she's going to know the latest. I've been in a different world for about the last year, so I don't know current state, but we didn't achieve some funding. I think we were looking for the final federal hurdle last year. We didn't achieve that, so the work has slowed down somewhat. But Dr. Christine Lee is still doing that work. It's just that the research project slowed down. So if you see Cindy in the front, she's going to be able to give you a much better update than I can. But thanks for the question.
Thank you, and I will follow up with you. Is this on? Yeah. My question is a practical one. Research teams form, relationships are built, and a patient-oriented research team, in order to do their work, has to be funded. And that's where we intersect with the world of the provincial and the national funders who give us these application forms that ask for in-kind contributions. And that's something that we always take a look at and we go, okay, how do we meet this challenge? It's either cash or it's in kind. So can you comment from your perspective as decision makers, when a patient-oriented research team is hitting one of those big dots in terms of the priorities, has a great question, and then comes and says, we need $50,000 or something like that, depending on what the grant is, of in-kind funding. How does that land on you, and what ways can the patient-oriented research teams come to you to present this to you clearly so you can contextualize what's being asked?
This is the one, Cindy. You and I have had lots of chats about this, haven't we? When you come to us, or come to me in particular with that there is no money. There is no money. $50,000 or $5,000. It's not sitting around waiting for a research project. So the thing that turns the wheel for me is, how can we align that to the return on investment in terms of patient outcomes? So having a patient present, in the case of Wayne, for instance, in C. difficile, just that example, we were able to learn as a clinical team, operations team, we were able to learn how that research would directly impact our bottom line. And so then it's much easier for me to go to my budget and justify the expenditure. So it really is tie in that because you may have the greatest research project and it's going to move some clinical area forward in a great way. But if you want my support, I've got to be able to justify the return on investment because I just don't have that. In the case of C. difficile, we held a nurse position to fund the research. That's the decision we're making. But we feel that's an appropriate thing to do, to hold that nurse position, which causes all sorts of other ripples to pay for that research. So sounds, awful, but that's the reality of my situation anyway.
Questioner, and could you please state your name and where you're from?
Okay. My name is Vikram Bubber. I'm from Surrey, but I generally get my healthcare in Vancouver and all over the place. And I know all the researchers in the room know that there are a lot of outliers, and I'm actually an outlier because I deal with 4 different health authorities in this area. And my question now is particularly to Linda. Linda, you're mentioning about the patient portal and access to information. My concern is that the health authorities are not integrating and talking to each other using one database, one centralized database for information for patients, but also researchers, at least getting the information, making it easier for the patient who is dealing with 4 different health authorities accessing the same information, because we all have one PHN number, right? Thank you.
Yeah, great question. Just so you do know that there is the ability for clinicians to see records across the entire Lower Mainland. So we do have the ability to see what is in, Fraser can see what is in Cerner, and Vancouver Coastal PHSA and PHC can actually see what is in the Meditech system. So there is an overlying thing that can, but linking all of the various databases is an absolute must, and there's a lot of work that's going on right now with the Ministry of Health putting together a data platform. I don't have the exact timelines of when that's going to be done, but it certainly is in the works and it's on the minds of many, many people. So it's an excellent question, and thank you for raising that.
Hello.
We have time for one last quick question before our break. Any takers?
Hello.
Okay.
Can you hear me? Okay.
Wait.
My name's Hannah Roy, and I'm a patient partner at Royal Jubilee Hospital in Victoria. I've heard some questions regarding C. difficile and transplantation, and I will be speaking on that later today. Not just the cost to the overall healthcare system, but also the cost to the patients and families regarding that treatment. So I just wanted to clarify that as well. It's called the digital storytelling of my patient experience. So.
Great, wonderful. We're going to wrap up. I want to give you a great big round of applause, please, to Denise and the little one, Mark, Anne-Marie, and Linda. Thank you so much.
Maybe I'll just use that. Okay. And I'd also like to offer my sincere thanks to the panelists and to Chad for taking time out of your busy schedule to be with us today and sharing your insight. Really appreciate that. I'd also like to acknowledge our funding partner, Michael Smith Foundation for Health Research, and Eleanor, who is with us to start off the event. So thank you so much. Please help me in thanking them. Before we take our first break of the day, I would just like to I would like to encourage you to take 1 minute right now and think about what key messages you're taking away from this morning and from the panel specifically, and then turn to someone at your table and share what your key learning was from that, or key thoughts about that. And also feel free, once again, to tweet about what you are taking away today. And also, don't forget the conference app. You can do that through there as well. Following the 15-minute break, during the break, please remember to visit our exhibitors. And at 11 o'clock, you will be heading out to your selected breakout session in the other rooms. And then I would just like to thank you for taking time and spending it with us this morning. And I will see you back here in the room for lunch at noon. Thank you.